way. I'd like, if possible, to open it up now. This is your chance. Fire away. What questions do you have for our experts about treatments, about new treatments, about the next wave of pulmonary hypertension? What do you want to see us do for you as we're working hard at all of the things that the panel up here has put on their wish list?
That's what I was going to say. Duncan, will you cure the damn disease?
Hi. Education of the medical system and the nurses. As you probably all know, I just came from the hospital and it wasn't even PH related, but there I am. It always comes up. And it's a good thing that I'm learning, and you have to be your own advocate, otherwise you don't get anywhere, and we all know that. So education is really, really important. And amongst the patients and our medical doctors and all the rest of it, and I'm trying, but they're not listening to me, but they're gradually, but I try and do it with humor. It's not fun, it's the pits, but this is where we're at, and we can't thank these guys enough for being there for us.
Diane, to echo your comment, we spend a lot of time educating as well. They don't always listen to us either.
But also to echo your comment that the brother or sister to education is communication, and that's the other big part that we have to work on as well.
Yeah. Hello. I'm just wondering, some of the things that you were describing, particularly about the small blood vessels and about the different things involved in the pathways, is it the same for idiopathic as scleroderma?
I'll try that.
It's going to get you on that one, Duncan, yes.
That's a very, very good question. And I don't think we really know, but it's interesting that a proportion of patients with scleroderma get what looks like the identical disease as idiopathic. So it's not, we can't really tell, it apart from the patient presentation, the blood tests we do, the hemodynamics, even histology. If we can, if there's a lung transplantation, it looks very similar. So there's got to be some commonality. There's no question. And the medications that work for idiopathic seem to work also for scleroderma. So again, that tells us that there's some similar mechanism. So that's interesting because it means that whatever is happening in scleroderma, and we don't understand that fully either, must have something to do with what happens in the lung in pulmonary arterial hypertension, I think. And one of the common elements would be the attack on very small blood vessels, which we know is a problem in scleroderma, and maybe part of why the skin becomes thicker and fibrotic, because it loses its very small microcirculation. And we believe that also happens in pulmonary arterial hypertension. So maybe that's the commonality there. So we've got a lot more to learn, but I think it's a safe bet that there's some significant overlap in those diseases.
Thank you.
I could add something. As Duncan said, not everybody with scleroderma gets pulmonary arterial hypertension, roughly 1 in 6. Why is that? They have the same disease, the same scleroderma. They can have the same features, the skin, the digestive system, but they don't get pulmonary arterial hypertension. We had a nice chat earlier in the Mythbusters Q&A about genetics. And clearly all of us carry genes for many different diseases. They don't luckily always get activated, which is good for us, but clearly that 1 in 6 people with scleroderma that got pulmonary hypertension has something different genetically that predisposed them. And so this is one of the very exciting areas of research in pulmonary hypertension, is that genetics that are going to help us with the precision medicine we've mentioned.
Thank you. Dr. Stewart, I'm just curious, when you're looking at the lining of the vessels and you think that there is something within the cells there, like how do you determine that? Do you have to have a biopsy of of the vessel to really figure out what's going on there?
Yeah, so again, yeah, we don't, I mean, it'd be great if we had biopsies, but I mean, it's not an easy thing to do, and it poses a significant risk, so it's not something that we would do normally. But we do get tissue, like transplantation, for example, so then we can examine lung tissue. It tends to be late on in the disease, so that limits some of the things we can learn from that tissue. And then we have, models that have been developed that mimic the disease in animals. And so we have to rely on those to sort of look at the initiating factors. So a lot of this, some of this is inference, but confirmed when we can look at the tissue from patients that have been transplanted, for example. And the other thing we're learning more about the genetics, as Sanjay mentioned in a minute. So there's strong genetic component to this disease. And one of the mutations is by far the most common in patients with this disease. Maybe 20–25% of patients may have this mutation, and it appears to be causative in some people, though not everyone with a mutation gets the disease. And so we can try to understand by the gene pathway, how does that mutation lead to the disease, and we know we can look at the function that gene has in these blood vessels, in these cells, and that will also give us insight into what may be going on at the very, very beginning.
Just to add something, Duncan was presenting to us at the medical think tank yesterday on the exciting research he does, and one of the neat ideas is you don't necessarily need the cell, but you need to measure what the cell does. And we mentioned before the 3 pathways. Endothelin gets pumped out into your blood. We can take a blood sample and measure that you have higher endothelin levels that might contribute to your disease. And there are other things in the blood that we're just starting to find, including work by Duncan, that might tell us what's happening to those cells without a biopsy. So that's a simpler way to get to the answer of what's going on.
So maybe I'll pick up there because since you opened the door. But it's an exciting new area. But when cells get deranged, they can release little bits of themselves, like little vesicles. So they're tiny. They're much smaller than a whole cell, and they circulate in the blood. And they may have a purpose. They may be designed to transport different molecules from one cell to another. So these they're called exosomes. So these exosomes can be identified, and we have some very early data. So I don't want to get too excited about this, but it may be that when endothelial cells are damaged in this disease, they squirt out a very specific kind of exosome that has a very specific cargo and signature. So we're exploring whether that's a biomarker, whether that's a marker of injury to the small blood vessels in patients, which could tell us about ongoing activity of disease, and it may be able to distinguish one kind of pulmonary hypertension from another. So very early days, but that's the kind of thing we hope, and it may not be this test, it may be others, but as we understand more of the biology, all these possibilities open up.
We have a few nurses here. I think if all of you are interested, we'll get a blood sample from all of you and give them to Duncan.
And I'll put them in my luggage and take them home.
Just a question in the back there. Oh, my apologies, sir.
Hello. Regarding the aggressiveness of the treatments and medications, are you talking about increased dosages, or are you talking about going from 1 to 2 to 3? And what are your views on, do you have any sort of information or documentation? Have you tried this far more aggressive approach within these therapies, and has that made a big difference?
Maybe I'll ask Dr. Swiston to tackle that one.
So could you just repeat the first part of your question again? So the question was...
The question is, when we talk about treating patients more aggressively, are we talking about higher doses of the drugs we're using or more drugs? And is there any data or proof that that's going to make a difference?
Yeah, that's a very good question, and that's obviously one of the, as we talked about with more medications available, the question of really how to use them becomes paramount. With some of the medications, there are set doses, so there's a dose that we put everybody on, and they stay on that dose regardless of whether there's changes in how they're doing. Some of the medications we titrate to what we perceive to be either effects, or sometimes we titrate some of the medications to what patients tolerate for side effects. But as far as adding the medications in, this comes a little bit towards what Dr. Mielniczuk was speaking about earlier, and risk assessment. And really when we feel that we're not in a place where the disease is controlled as well as it should be is when we consider adding in further therapies. And so we tend to, the feeling is that if the disease is not well controlled, then we add in another medication, then add in another medication. Obviously, in the current, as also been discussed, in the current sort of landscape, once we've done that a couple times, then we do run out of medications at some point, and we have to look at other options. And for those that are on the parental therapies, we do at times increase the medication in relation to what we perceive to be control or lack of control of the disease. But we do that. We do that with some a balance between being conscious of how much total dose we have patients on, because we do know that with some of these medications, too much is a bad thing as well. Is that do you want to?
Perfect. I want to add something about aggressiveness. This is actually a bit of a controversy. The standard approach, as John laid out, is start drug A. If you're doing great, we're pretty happy. Most people don't do great on one drug, add a second drug, and eventually maybe a third drug. So maybe that's absolutely wrong. We have colleagues across the world, PH experts in their own right, that believe you should start on all three medications at once, get you as great as we can get you, and then maybe you don't need them, we can start to get rid of a drug. So very much like the ideas you've heard from Lisa and Duncan, PAH is like a bit of a cancer. If anybody's had cancers or tumors or family members, it's very rare they try gentle chemotherapy first. If that doesn't work, let's be more aggressive. And so you're going to hit it hard, as we like to say. So maybe that's the answer in pulmonary hypertension, to be more aggressive in all of you when you first show up. The challenge is it's expensive, there are side effects, and we don't know if you need it. So that's what's being sorted out right now. Clearly, very importantly, there's data that 2 drugs from day one is better than 1 drug. So that data is coming.
So, Dr. Mehta, does that mean that nobody should be on one drug?
I can't say no because I have patients on 1 drug. And the truth is, again, if it was me and I wasn't that sick to start with, I would try 1 medication, but I'd be very quick to take a second, maybe a third if I wasn't fantastic. So we are more aggressive than we used to be, exactly as John said, using this risk assessment. How good are you? How good can you be? And how good do we want to together decide you should be? But there are people that respond dramatically to 1 medication. And again, the idea, they're different. They have something inside them that makes this medication the perfect medication for them. They are almost normal. So then I don't want to add a second medication. That doesn't make a lot of sense in terms of risk and side effects and costs. So yes, there are a small number. I would have estimated now 10%, maybe 20 at the most, 1 in 10 to 1 in 5.
I noticed things over the years. Have bettered with communications between the doctors. Like I remember times when I have 3 specialists and they wouldn't communicate, but I think that's really improved like in a few years. But my question is how come it's so much, well, not so much, but you know, different out here? And it seems like there's more information back east, like in Ontario and Quebec. But out here, yeah, we have amazing people, absolutely. Like I have a wonderful doctor I've had for 15 years. I also have 3 wonderful specialists, an ENT, lung specialist, and of course, my heart doctor from the Diamond Center. But it seems like there's so much information over that way and less over this way. I'm just wondering.
Maybe I'll ask if I may, maybe just turn the question around a little bit and ask my panel, how do the doctors from the east to the west communicate, and how do we all share knowledge, and what are we doing to make sure that we all are in the loop, if you will, with everything that's happening?
Well, I guess as a group, the physicians in Canada, the pulmonary hypertension community in Canada is actually is actually quite well integrated and I think very tight in that I think every pulmonary hypertension doctor in Canada knows every other pulmonary hypertension doctor in Canada, and we do take every opportunity that we can to meet regularly. Just by way of example, we had a day-and-a-half meetings leading up to the meeting today, which included physicians from all the way across Canada, including Ontario and including Quebec, British Columbia, Alberta, and I think that was what we had represented yesterday, right? Yeah. We do have regular meetings. We have committees both through the Pulmonary Hypertension Association of Canada as well as through the Canadian the medical side of our specialties, which are the Canadian Thoracic Society and the Canadian Cardiology Society, and with those we have regular meetings as well as some more informal methods we have of staying in touch and collaborating. I would argue that the groups in Canada are all fairly cohesive, and I think all doctors between clinics or even within clinics operate a little bit differently. I think even within the pulmonary hypertension clinic in Vancouver, we have slightly different ways of operating. I think that's true across Canada, but I think that as a whole, barring the differences in access to medications, I think most of the pulmonary hypertension physicians in Canada practice within a relatively similar spectrum. If you want to comment on that.
Absolutely. I think I would agree with that, just because we do communicate often. In fact, not just communicate, we work together. So if you read papers that come out on pulmonary hypertension, many of us work together to write those papers and create educational programs. I think I understood the question a little bit differently. Were you asking about communication between the Pulmonary Hypertension Center physicians and community specialists?
I'm just saying that some doctors didn't know what the other doctor was doing, like in the past, my physician didn't get the message on to my other doctor, and I'd have to explain. And then now I notice that, they're having computers, and, it's like a circle. They're passing the information on,
Well,
which is very important communication.
Right.
I just wanted to say one more thing before I go. Sorry, yapping away here. I think most people would prefer that a medication would help them rather than have a transplant, because you're just basically exchanging your disease for another disease, right? No, I'm just saying, it will extend your life, but you still have to take medication, and and it doesn't always work. So I think it's wonderful, all the research you're doing to help people with medications, and something more simple than transplants and building 3D hearts, because we all know, well, not all of us, but I do a lot of research. Hearts do not last very long. Once somebody passes away, they only have a certain window, and not many, you don't know, and it's difficult for a family member to, decide whether they're gonna, especially if the person's young. So I think we'd prefer to see less death and more medication help. Well, thank you very much for your time.
I think you're absolutely right. Of course, transplant is the last resort that we don't want to have to use. Back to your previous point, the communication. I think the challenge is we know what we're doing and saying, and we hopefully look after you best we can, but your other doctors, your family doctor, your local specialists, don't always understand this. And in the past, it was a bigger issue. They would see pulmonary hypertension and just get scared. Well, I don't know what to do. I've had family doctors say, well, I can't even adjust their heartburn medication because they have pulmonary hypertension. So that obviously doesn't make sense. And this is our job, PHA Canada and the physicians. We have worked very hard to educate people about PH and the fact that we will look after that side of it and we'll help you understand it, but still be involved and look after the other issues that your patient needs. If people live longer, which they are, which is fantastic, you're going to need general health care. You're going to need cancer screening and your diabetes looked after and your heartburn looked after, all of those things that family doctors do a great job of. So it is our job, and I think we're doing a better job of transmitting that information and sharing knowledge about PH.
I think we have time for one, maybe two more questions. Yeah, I think there are still some hands. Yeah, quite a few hands, actually. Yeah. Okay, perfect. So go ahead. You drive.
So I was wondering if the panel could comment on what they need from the patient community in order to be successful in advancing their research.
I think one of the things we need is involvement, which is what we see in the people here today. Sorry, the involvement, which we see in the people here today, and advocacy, because there is sometimes patients underestimate their voice, and not just to the medical community, but to the political community. And there are many things that patients can say to their health authorities, to their ministries, to their governments, that the medical community can't say. And so that's, I think, one of the places that we really, really value the collective support of the patients.
Maybe I'll add to that, that we're beginning to understand, and I don't know why it's taken us so long to understand this, that it's really valuable that patients also participate in helping us decide what trials to do, how to do these trials, also in selecting what are the endpoints that are most meaningful. For many years, physicians thought they knew all this, and it's not always the case. So I think this is a whole new field of patient engagement that really has tremendous benefits in trying to help us identify the real important targets, both in terms of the way we do trials and also what we use to measure, so we know whether or not whatever we're doing is helpful.
I do have a question, but I just want to make a quick comment. First, I just want to thank the Pulmonary Hypertension Clinic for even being there. I had a new doctor a year ago, and when I was telling her my ailments, I just told her, and then I said, oh yeah, and I have pulmonary hypertension, and I saw the look on her face change. And then I said, I'm followed by the PH clinic, and I saw her face change again. And so I really thank you. I do not take that clinic for granted. It's fabulous. My question is, and it's a bit of a weird question, but I'm very interested to know the answer. Many people donate to the, donate their organs and have written on their driver's license and everything to donate their organs. Mine are not in good condition. I have pulmonary hypertension. Is it of any use when a person passes away in research to have the lungs of somebody with pulmonary hypertension?
Maybe I'll ask Dr. Stewart to take that one.
Yeah, I think it really is. I mean, I think, and again, something that, in Canada we could probably do a better job in terms of having a coordinated system to allow that kind of valuable resource to be available across the country to people doing research in this area. And we've talked about that. I think we've made some steps forward, but I think we could do a lot more, and we can learn from some other countries that have done this quite effectively, because you can learn so much, and we should be learning whenever a transplant's done. I mean, I think we should be learning from the organ that's taken out, the diseased lung, and really, adding that to our understanding of these complicated mechanisms.
So is there something from this conference that can make a recommendation somewhere to make that happen, rather than us just say it'd be a great idea?
Yeah, it's the kind of thing we discussed in this meeting we had leading up to this. So we had all the PH physicians and many of the people doing research in the area together, so it's something that we need to. I think we know we need to do it. It's a little. There's things that need to be done to do that. There's obviously issues in terms of privacy and other things that we need to be able to solve. But we do have access to places, biorepositories where organs can be stored. It's a matter of putting into place the mechanism so we can share this. And it's beginning. We just need to take it the next few steps further.
My question is, I'm on 3 different medications, and not one of them is covered in BC. Why is it taking so long?
We'll take John. John will take that one.
That's my
'cause-
question.
What have you been doing, John? Come on.
Shifting my seat. So, so the landscape for medication in British Columbia has been certainly evolving over the last number of years. And it's really been in the last 5 years. If you look at there are now 3 medications available for pulmonary hypertension that are not universally covered in British Columbia. And I say universally covered because all 3 of those medications we have had approval from Pharmacare in isolated cases to have covered. Some of it is related to the political landscape, and there has been a change in government over the last number of years, and we're hoping with that change in government, there is going to be a change in policy and a change in general approach to medications. And to the best of our ability, we are working with the government towards some of those changes. And as you know, PHA Canada has been very active in providing that, as what I was saying just earlier, that patient advocacy voice, which is very important. My hope is that with the change in the landscape, these changes will come one way or another. There are a couple different ways that the changes can come about, whether it's a change to allow the medication as a general prescribing practice, another is within the pulmonary hypertension clinic, and another also is on a case-by-case basis, and which is kind of where we're operating right now, but not as a formal process. So hopefully the medications will, British Columbia will start to evolve a bit and catch up as time goes on. But in some respects, we're a product of the previous government that we had that had held off on approving a number of medications. So, but hopefully that will change.
We have people here probably from 6, maybe 7 provinces, and the problem is all of you are different. Your governments have decided differently which drugs they're going to cover at what phase of your disease and what they're going to pay for them. This is the crazy Canadian landscape. To get a drug paid for, there's 4 steps. Health Canada says, yes, it's a good drug and safe. All 10 medications have gone through that. Then CADF, CDR, a national body, says, well, is it an addition to what we already have? And is it cost effective? Then there's the Pricing Alliance, PCPA, and finally there's each province. That's ridiculous. It takes at least 2, sometimes 4 to 5 years to get approval. Have you heard of National Pharmacare in the media? So this is a big discussion, not about every illness, that's important, but also rare illnesses like this. And this is going to be a bigger discussion over the next few years that PHA Canada is already starting to participate in. And so is that the answer? Possibly.
All right. I don't know if there are anyone
One more.
with
Sorry.
a mic. Yeah. Okay, last question.
The best for last. I was diagnosed about 16 years ago, and 14 years ago I went to Toronto for some testing. I'm from Newfoundland, and they discovered that my spleen was non-functioning. It was shriveled up. At that time, they told me that they thought there was a connection with a non-functioning spleen and pulmonary hypertension. I was idiopathic. And they just didn't know what the connection was. I'm just wondering, has there been any advancement in that, and how common is it with pulmonary hypertension patients? Dr. Stewart, I'm thinking, but.
Stewart, I think she's
I
asking
think
you.
I'm the last person that should answer this. I think Dr. Mehta would be the best person to deal with this one.
So it is interesting. One of the, I think the most exciting things about pulmonary hypertension is we used to think this was a lung disease. And guess what? The rest of your body was fine. The heart got a little weak because of the pulmonary hypertension, but we focused on the lungs. There is more and more information that many patients with pulmonary hypertension have actually issues elsewhere in the body. We've talked about scleroderma, and that's a systemic disease. So our friends, again, in Quebec City have looked at different mutations that are present in the lung in pulmonary hypertension and found those similar mutations in blood vessels in muscles. So when you can't walk, it's not just a lung-heart issue. The muscles may not be normal. So there's lots of information coming that there are little effects throughout the body. So specifically the spleen, there is an association if spleen doesn't work or you've had it taken out and getting blood clots in the lungs and CTEPH. There has not been, to my knowledge, an association yet with PAH, pulmonary arterial hypertension. I don't know, Sonia, what kinds you have, but at least for CTEPH, there's a very strong association.
And in fact, if I can jump in, this was discussed every few years. There's a world symposium on pulmonary hypertension where the international experts get together and think about the disease. And it was discussed this past winter. Still, 5 or 12 or 15 years later, we don't understand that relationship. And so much so that it may not even continue to exist in terms of an uncertainty because we haven't moved the field forward. So it may be related or it may not be, but we're not much further ahead in that understanding. All right. Well, maybe I'll take the moderator's prerogative then to first of all to thank my friends and colleagues on the panel for doing a great job, and thank all of you for listening this afternoon. You've heard some really exciting things. I want to leave on a very positive note. We are moving the field forward, and it is continues to move in a rapid pace. You've heard about using the same drugs differently. You've heard about understanding new pathways. You've heard about new drugs, and you've heard about this concept of personalization, that maybe the next wave of pulmonary hypertension will see us tailoring our treatments for very specific markers in our patients to give us the best effect from what we have. So I will stop there, and thank you very much for your attention this afternoon.